How many of you have ever been to the ER? Whether you were going for yourself, with someone, to see someone, how many of you have stepped foot in an emergency room? Anybody? I know I have. Never for myself, always with someone though. How many of you can say you had the exact same experience while you were there as the person sitting next to you? Anybody? I didn't think so. You see, in the ER, there is no set theorem, no set formula, so that everyone can have the exact same experience. We're only human. Now, what exactly is emergency medicine? What is the ER? What is its purpose? Emergency medicine is the medical specialty involving undifferentiated care for any illness, any injury, for any person. Now, I chose this field for a multitude of reasons, and that's what leads me to my quote for this year. Then I heard the voice of the Lord saying, "Whom shall I send, and who will go for us?" And I said, "Here I am, send me." To me, this quote is so much more than just a biblical verse. To me, this means take initiative. Take hold of your life. Know what you want and go for it. Say, "Hey, send me. I'm going to step up. I'm going to do this." And that's part of why I chose the ER and ISM this year. This is the call I feel has been placed on my life. People are my passion. The one that doesn't falter, the one that never fails, the one that doesn't go away. I want to care for them, I want to help them, and I want to advocate for them. And that's part of my long-term goal, which is vocational medical missions. Now what that means is that I want to spend my life, my job, to go live and practice medicine in a country outside of the United States. That also is part of the send me, is knowing that this is what I want and being willing to surrender myself to the process, to put in the effort and say that I'm going to make this happen, not for anybody else, but for me. And the first step was ISM. ISM stands for Independent Study and Mentorship. And it really is exactly what it sounds like. Independent study and mentorship. First semester we spent much of our time doing research, figuring out what exactly our field actually was, what it took, and what it consisted of, while trying to make and find contacts out there of people that we could interview, that we could hear real-life experiences from, that we could maybe find a potential mentor. And that's when second semester comes in. When we get done with the interview process and we've done a lot of our research, we ask someone to be our mentor. And then we spend the rest of the year going on mentor visits. For me, that meant spending time in the hospital, going to administration meetings, sitting with my mentor and talking about life experiences, things that have happened to him, things that have happened to me, and really getting to see what it's like firsthand to work in a hospital. It's been amazing. ISM was definitely worth it. Now, like I said, independent study. That mostly consisted of research. One of the main things I researched, one of the biggest issues that I've tried to figure out for myself this year is something that I would like to call the most common debate. Which one do you pick? Doctor, PA, or nurse practitioner? I have been asked this question by every single medical professional that I've encountered this year in ISM. Do you want to be a doctor? Do you want to go to PA school? Are you going to be a nurse? Which are you going to choose? And that's something I can't say I've really figured out. I've spent this year shadowing a lot of nurses, a lot of NPs, and a lot of doctors. And I would have to say that my goal right now is still to go to medical school. But that if I were to end up going to nursing school or becoming a PA, I would be just as satisfied because they're all amazing people. Now, what does this common debate consist of? A doctor. A doctor has a PhD. They don't need supervision to provide people with medical care. They can specialize less easily, however. Once you've done your residency, it's really hard to go back. You have to start over each time. They also can write prescriptions, and it is the highest level of care possible. A PA. Now what a PA is PA stands for a physician's assistant. They work alongside doctors on the team with doctors. A PA can practice medicine fairly independently, but they have to be supervised by a doctor on their team. They can write prescriptions, they can see patients on their own, but they are overseen by a doctor in the end. And a nurse practitioner. A nurse practitioner is the most advanced nurse. They have a lot more independence than a normal nurse does. They are the same concept as a PA, but their degree is in nursing. They can really see patients on their own and control care on their own, but they are overseen and a part of a team with an attending physician. Now, I have another question. How many of you in here have ever had a headache? Anyone? I know I have, a lot. Now I want you to try to put yourself in that position. Go back to that day when your head was pounding and your heart was racing and you thought your brain was going to literally explode. Can y'all remember that feeling, the worst headache you've ever had? Can anyone in here tell me that they've been to the ER for a headache? Anyone? No? Me neither. Can anyone in here tell me that even in the most dire of pain, would they go to the ER for a headache? No? Alright. Hold on to that thought. See, now we're going to play doctor. Put yourself in a doctor's position and you have a bunch of patients coming in all at once, but you only have 3 available rooms. You have a patient coming in who's had a stroke, a patient with a headache, a patient with joint pain, someone who's had a heart attack, respiratory distress, a toothache, a rash, and a seizure. You have 3, maybe 4 empty beds. Which of these are you going to give a bed to? Right. Probably the stroke, the heart attack, respiratory distress, maybe after the seizure. Right? That's the logical thought process, correct? Alright, I thought so. That ties me into my original work this year. Original work was something that we had to come up with on our own. It was a concept that we created and researched and figured out all for ourselves. Now, for my original work, I looked into the top 10 reasons for ER visits in the United States. The emergency room protocol and public opinion. Most of the public has a terrible opinion of the ER. They only have bad things to say about it, they only have bad experiences, and I really wanted to figure out why. I wanted to see if I could tie all of these things together and find a common cause. If people really knew how the ER worked, what the protocols were, when you got to be seen, if any of the public opinion was based on actual knowledge, or if it was just human nature, egocentricity, me first. And how that ties in to the top 10 reasons for ER visits is I wanted to see if people knew what they were. If people would actually go to the doctor, go to the ER of all places, the emergency room, for a headache. Because a headache is one of the top 10 reasons for an emergency room visit. I found that to be shocking. Now, what did I ask in my original work? I sent out a survey to figure out all of this information. In my survey, I had age, gender, if the person had ever even been to the emergency room, if so, why, How emergent is a headache on a scale of 1 to 5? Would you go to the ER for a headache? Which is the way in which it is decided who gets to be seen first in the emergency room? What percentage of people do you think leave the ER without even being seen by a physician? If they leave without being seen, was it a true emergency? As well as how effective do you feel the current ER system is and why? This is my spreadsheet of my results. As you can see, it is a jumble of information, but let me explain. My brain works best in color. I color code everything. It helps me understand what's what. Now my spreadsheet, this has every response that I received. In this column, we have age ranges, then we have gender, if they've been to the ER, why, and all of the rest. Now this column right here, this very multicolored column, is where I ask, which of these constitutes an ER visit? I listed 9 different things out of the top 10 and said, which of these would you go to the ER for? And have people check each one. Now there was a correct answer to this question, and that's why I was able to differentiate as such, is that there are certain ones on the list that do constitute an ER visit based on medical conditions and things that are on hospital websites. I did all of that research prior to. Why? What was the purpose? What did I find out? What I found out is that most people know the right answers. They know what constitutes an ER visit. They know the protocol. They know how it works. But that's not what matters. What matters is me, you. When you're in that moment of panic, of pain, whether it's you, your child, logic is the last thing you're thinking about. And I know, I understand. It's hard. It's hard to really understand why you can't be seen first. But that springboards me into my final product. For my final product, which many of you saw at my booth earlier, I decided to write a novel. I decided to write a novel, more like a short book, that was really a guide to the ER. How to use it, what to do. In its simplest form, how the ER runs. Because I think that we need to work on public awareness. I want the public to be able to understand what's really going on. To say that they know why things are happening. Because when you get to the ER and you're in an emergency and you're so worried, you want to understand, you want to know, and you want to try and get away from the frustration. That's what I was trying to do here. I researched different insurances, co-pays, everything that could be a part of your decision to go to the emergency room. Telling people how best to utilize it, when to go, what to expect when you're there, and how to maybe take a few calming breaths, take a step back, and say, you know, if I'm not being seen first, maybe that's a good thing. It means I'm not dying, which is pretty important. I got this idea from my mentor, Dr. Rustin Morse. Dr. Morse is an attending physician at Children's Medical Center Dallas and at Children's Medical Center Plano. He is also the chief of quality care at both campuses. Now, quality care. Quality care before this year, I had no idea what quality care was. I heard him say that when we were introducing ourselves to each other, when we were having our first interview, and I said, forgive me, but what is quality care? And I was shocked by his response. The quality of care department is a bunch of physicians and hospital administration that all came together and work to make the hospital a safe place for everyone. They look through every single case. Every time something has gone wrong, every time a parent complains, everything to try and make everyone's experience at Children's as amazing as possible. I was stunned. I didn't even know something like that existed. I got to witness a quality of care meeting with Dr. Morse and see the proceedings in the children's hospitals, and it was an eye-opener. Not only did I have no idea that there were so many incidents in a hospital that needed to be addressed, but I didn't know that there was a committee that specifically worked to address them and make sure they never happened again, because they worked on affirmative action. They would make meetings, they would talk to hospital education, they would do everything in their power to ensure that everyone knew what the right steps were, how this could never happen again, as well as looking into every case where a parent thought that they didn't get what they deserved, and tried to make it right. It was amazing. I was in awe of the initiative that these people were taking and how much they cared, how much they advocated for their patients even after they had left the hospital. Some of my experiences in the actual emergency room were mostly met under the supervision of a nurse named Jamie Ostrom. Now, I spent many hours with Jamie in the ER, and I saw many things that I can't tell you all about because we'd be here all night. But I have picked a couple of the highlights, a couple of the most amazing things that I've ever experienced, that I've seen, that really proved to me that this is what I wanted to do, to share with you. Some of these consist of my tour of an ambulance, which was amazing. And there are no words. Those people that work in the ambulances, the EMSs, wow. They have to do everything that an attending physician can do in the hospital in a moving vehicle. They have to be able to intubate. They have to have all the necessary equipment. It was a very amazing learning experience getting to have that tour and a talk with an actual EMS. Things that I never actually knew or really understood. Also, intubation, which is a fascinating subject, CPAP and BiPAP, RSV, which stands for respiratory syncytial virus, testicular torsion, and Soto syndrome. These are all things that I saw this year that I really wanted to do further research on, or experiences that I had that I wanted to share. Now, I have another question. Has anyone here ever heard of degloving? No? Okay, well now I'm going to show a picture, so if anyone is squeamish, you may want to turn away. This is degloving. It's a little gross, I know. Not a fun thing. Basically, think of your skin as a glove, like you would wear in the winter. Now imagine taking that glove off. When you take off a glove in the snow, nothing underneath is hurt. Your skin isn't broken, nothing has changed. It's the same thing with degloving. It's like pulling your skin off like a glove, and everything underneath usually not harmed that bad. Your tendons are still intact, your muscles are still where they're supposed to be. There's not really even that much bleeding. Just like in this picture, just scoot it up like a glove. On my very first day in the emergency room, this is what I saw. This really proved to me that no matter what, I could probably stomach it. It was amazing. I walked in and the doctor was just moving it around and trying to show me, and I didn't even feel a little bit queasy. He was very impressed. Now, another really impressive thing about children's ER, probably specifically, is the dynamics. How they work together, how they all care about each other. It was amazing getting to see some of the politics behind running a hospital. There's triage 1, triage 2, charge nurse, everything like that. Jamie is a charge nurse most of the time. A lot of the times when I went to go and shadow her. And it was a really fruitful experience because I got to see how much she went out of her way to make sure that everyone working under her was having a good day. Getting them anything that they needed, making sure that they weren't stretched too thin. Because really there are a lot of politics involved with being in charge. Trying to keep everyone happy can be pretty tough. Triage 1 and 2 are things that I got to experience a lot as well, because when Jamie was charged, she would switch off with the triages a lot. Triage 1 is the first nurse that you encounter when you come into the hospital, the one that gets your name, your birth date, and what is wrong with you, while taking a first assessment of you, which is so important. I never had any idea, but the Triage 1 nurse can tell a lot. Triage 2 is the second nurse you see. When usually you go into a room, they'll take your weight, your blood pressure, really find out in detail what happened so that they can assign you an acuity number and get you in to see some docs. Now, these may seem kind of the same, but they're really not. They serve different purposes, and getting to experience both was an amazing experience. RSV. RSV stands for respiratory syncytial virus, which I always saw at least one case while I was in the ER every time. What it is it's the precursor for pneumonia or bronchitis in infants. It causes a lot of respiratory distress. Usually they have to put them on a BiPAP or a CPAP, which is a breathing apparatus, to try and add some pressure to the air to force it into their lungs because they're having so much trouble breathing. It can be very scary, and at its most heightened state, it can lead to intubation, which is never an option in the ER. You almost never want to intubate a child on the floor, because once you've intubated someone, there is a chance that you can never take the tube out and that they won't be able to breathe on their own. Now, RSV was one of those things that they would say, RSV, and I had no idea what it meant. I would be walking around the ER and they would say, oh, we've got another RSV. And I was just kind of like, Jamie, I don't know what that is. And so I took it upon myself to do some more research on it, figure out what it is. And really, it was a pretty interesting topic. And it was really cool once I understood to be able to understand the different steps they were taking to treat it, everything they were doing to assess the patient. I had a better understanding of why they were doing those things and why those things were necessary. Another thing that I saw every time that I went into the ER was testicular torsion. The nurses even started to joke that maybe I shouldn't come anymore because this really is pretty rare. Now, what testicular torsion is it occurs when the testicle rotates or twists of the spermatic cord and traps the blood in the scrotum. So it adds a lot of pressure and it hurts a lot. Now, you see, the bad thing about testicular torsion is that if you don't fix it quickly and efficiently, it can lead to infertility, which is one of the main reasons why when a kid comes in who is even suspected of testicular torsion, they get sent to a room immediately. They take infertility very seriously at the ER. And it was very interesting being in Triage 1 and getting to assess by watching gait, by watching how white the knuckles could get, how much these kids really were in pain, how much this really was a very scary reality. Last but not least is Soto syndrome. Has anyone in here ever even heard of Soto syndrome? No? I hadn't either. We had a child come in who was having a lot of breathing distress. He had had a couple of seizures, and the parents told us that he had Soto syndrome. I started to carry sticky notes in my pocket on about my third time in the ER, and I took one out and I wrote that down so that I could research it later, because Jamie was very busy. There were a lot of people in that day, and I didn't want to be a nuisance, more than I probably already was. Now, what Soto syndrome is it's cerebral giantism. It's a rare genetic disorder caused by mutations of the DNA. What it can cause is disproportionately large and long head, slightly protrusive forehead, pointed chin, large hands and feet, down slanting eyes, mild cognitive impairment, delayed motor cognitive skills, delayed social development, low muscle tone, speech impairments. The list is extensive. This is a very serious condition, and now that I know what it is, I can think back on seeing that child and how hard it was to care for him, and I understand why. I'm one of those people that always likes to know why. I like to know the reasons for things, why they are the way they are. And this child, he didn't want to be touched, he didn't want to be helped, and he just kept seizing and seizing and seizing. He had had 6 in his first 5 minutes in the ER. It was terrifying. And I can't even imagine. His dad called it the genetic lottery. The genetic lottery, the lottery you don't want to win. Soto syndrome is something very serious, and now that I know what it is, I will definitely take that knowledge and I will be able to use it. To wrap up, some of my goals. A lot of my goals have been achieved this year in ISM. I finished final product before final presentation night. I got a mentor. I got to experience amazing things. Now it's all about moving forward with everything that I've learned and everything that I've accomplished, all of the connections I've made and the people that have helped me. Graduating high school, that's an important first step. Going to college, getting my degree, going to medical school. Medical school is the biggest one. Going to college, making the grades, putting in the effort to continue with my dream so that I can go to medical school and become a doctor and get to be the one that cares for these kids, for these adults, for any of the people that would come into the ER and would need my help. I have ISM to thank for that. Before this year, I was lost. I kept letting everyone else's opinions and everyone else's thoughts of what I should do with my life run me. But I got tired of it. I got tired of listening to them. I got tired of being told I couldn't do it. So I took the initiative. I said, hey, here I am. Send me. Let's do this. And I have not regretted it a day since. Thank you.